do about that. But first of all, I want to be talking with you. What's sort of the state? This is sort of the State of the Union address, I guess, the state of diabetes in Indian country. Where are we at? So some of this data, some of you have seen. In fact, some of it we talked about at the last conference 2 years ago, but some of it is quite recent. But all of it is saying that we're headed in the right direction. Have we fixed diabetes? No, of course not. But we are moving in the right direction, and some remarkable improvements have happened. Gail noted that I've been in Indian health now for 29 years, and in that time, when I first started, we all despaired. Back in 1990, diabetes was going up, complications were going up. We were all worried that things were going to be, we would never be able to turn this around. But I hope you'll be convinced in a few minutes that we are starting to do that. So I'll first start off by talking about that, and then talking about some future directions of things we could do, in our next gen, if you will, on diabetes in Indian country. So many of you have seen this. This is still the current CDC National Diabetes Statistics Report. This is looking at prevalence of diabetes among racial groups in this country. We are on the bars on the left side. This is by gender, so male and female. But between male and female, it's at 15.1% for American and Alaska Native people. That's still the highest of any racial group in this country, but it has plateaued, as we'll talk about in a few minutes. And unfortunately, for a couple of other groups, they're still catching up with us a little bit, so the gap is actually closed a little. But we're still the highest. We haven't changed that part around yet. So in the 1990s, as I just said, the prevalence of diabetes and its complications were rising. And as a result, Congress acted by establishing the Special Diabetes Program for Indians, which now is a $150 million a year grant program, which many of you are SDPI grantees and know that those dollars go to your communities to help you in diabetes prevention and treatment in ways that wouldn't be possible without the SDPI. And we currently have 301 grants in tribal, urban, and a few IHS facilities across the country, 35 states, in fact. So there's a lot of resources that SDPI helps make available. Some of them we coordinate through our division. One important thing is data. We wouldn't know what's going on if we didn't collect data. I know you all enjoy doing that every year. Oh, really? Oh, come on. But yay, audit, there we go. The data nerds are fighting back. But without that data, we wouldn't be able to make the case to stakeholders like Congress and others that we are making a difference. And so that Diabetes Care and Outcomes audit, over 123,000 patients with diabetes, charts with diabetes last year, looking at over 40 care process and outcomes. It's a remarkable data set that we're able to look at. And I know Karen Sheff talked about that yesterday at her session, and will again throughout the conference. But this is an amazing thing that gives us that ability to get that picture of what's happening and show the progress. We've created resources just for our population. We know that diabetes education materials that look like our people and that have literacy levels appropriate to our folks, that speak to the realities in our lives and communities, people are more likely to pay attention to. So we've been creating those for a while. We've also had clinical tools. We've had diabetes standards of care since before the American Diabetes Association did, back in the 1980s. We did it 2 years before they did. All these trainings, webinars, both, and online, and of course conferences like this. All these things together help us all to have the resources we need, the knowledge we need, the support we need to take the best care of our patients with diabetes, and to help prevent diabetes in those without it. So many of you have seen My Native Plate, an adaptation of the USDA's My Plate, but adapted to our communities. And this is just one of many patient education materials. These are available at our booth. Hopefully you guys will check that out. It's just right in front of this ballroom, the Division of Diabetes, and these things are available for free. You can pick some of these things up here, or you can order them for free in our online catalog. We'll ship them to you for free as well, so that you have them for your classes and your health fairs and for your patients in clinic, whatever you need. And you're not going to read that either off of a slide, but we also do treatment algorithms for clinicians. For many years, we've known that we want to make every visit a diabetes visit, whether they came in for diabetes or they came in for urgent care for a sprained ankle. If their blood pressure is high or their sugars are not well controlled, we hope those providers will use algorithms like this to maybe take a minute to adjust medications and make that one more place where we can help our patients achieve better control of these risk factors. So over the years, we've seen with SDPI funds and other kinds of efforts, we've seen a real increase in the availability of these resources, of these clinics, of these services that make a difference for people with diabetes. So we're seeing more diabetes care teams. We're seeing, of course, physical activity specialists and all kinds of things, as you're seeing on this slide. And the comparison from 1997, around the time that SDPI started, and these data is for 2013, but it's fairly similar even now. You see tremendous increases in the availability of these services across the country. So if all of this, it makes us ask the question, so is it working? Well, of course, I already gave away the cliffhanger on that one because we know that it is. So what are the things that we're seeing that are going well? So diabetes prevalence, we know that in our adults with diabetes, that the years of increasing prevalence stopped around 2011. It was going up and up, but it actually has been at least plateaued since 2011. And in our youth, the rise in diabetes prevalence actually stopped at least as early as 2006. We can't go back further than that because that's as early as our data in the National Data Warehouse is good enough to make statements on. But we know it stopped at least as early as 2006. Sure, we still have people getting diabetes, both adults and youth, but at least overall, what we're seeing is it's not getting worse. Childhood obesity, we know that the prevalence of that in our youth has been nearly constant, and that study was from 2006 to 2013. So that huge risk factor for diabetes has also not been getting worse. It's been at least stable, and again, that's better than we thought we were going to be seeing at this point. This is recent. This just came out. Our partners at the Agency for Healthcare Research and Quality just in December came out with a data spotlight that hospital admissions for uncontrolled diabetes in our population has decreased 84% from 2000 to 2015. That's a huge decrease in hospitalizations for this. So our patients are having less trouble with being out of control with diabetes. That, of course, saves money, which always makes payers like Medicare and others happy. But more importantly, that means our patients are not as sick and not feeling as badly as they do when sugars are so out of control. So diabetic retinopathy, the eye disease of diabetes. You all may know our IHS Joslin Vision Network program, the telemedicine program that allows, that puts imaging devices in clinics and images of people, the eyes of people with diabetes are sent for readings at Phoenix Indian Medical Center, and then those readings are returned to you all locally so you can follow up with your patients on that. That way they don't have to see an optometrist or ophthalmologist just for their retinopathy screening. Other reasons you can to see those folks, but you can save those services for other reasons. There are glaucoma and there are other things because you can get it done through this. Dr. Dawn Clary is the coordinator currently for the JVN program. She has a table out on the that side over by the Sky Bridge. Please go talk with Dr. Clary if you don't have JVN and see about getting part of that program. But that program has been around since the year 2000, and it's really an exemplary telemedicine program. So, and one of the things that has allowed us to do is that there's been a lot of data on people because it's been around for quite some time. So a team, including Dr. Mark Horton, who just retired from IHS, head of ophthalmology, chief clinical consultant about a year ago, but they took a look at data on about 54,000 of our patients and found, who participated in the JVN program, and found that looking at the prevalence of diabetic eye disease, whether it's macular edema or retinopathy, and then comparing to reports on eye disease from the 1980s and 1990s, that the prevalence of those kinds of eye disease had gone down by more than 50% over those years. So cutting it in half. That means far fewer of our patients who go blind from diabetes and who have to have laser treatments and other kinds of things to try to stop their eye disease. That's a wonderful thing. And of course, many of you have heard about this good news on kidney failure. And 2 years ago, we published with some colleagues at CDC and NIH a vital science called Native Americans with Diabetes, a Better Diabetes care can reduce kidney failure, because we use data from Medicare data from the U.S. Renal Data System, the U.S. Census, and our diabetes audit to take a look at the state of kidney disease in our patients. And many of you know that for many years our rates of kidney failure were going up and up. But right around 1996, 97, they started to turn around. And so we're that black line, which on the left side, we're the top line. But as you can see, we are the line that is just doing this. We are just dropping and dropping over those years. So that by 2013, we had decreased new cases of diabetic-related kidney failure by 54%, just like the eye disease dropped by more than half. That's incredible. That's you guys out there every day working with your patients to get their blood pressures and their blood sugars controlled. They're working hard at home to do all of the self-care things they need to do in order to make that happen. And you all know that this is a marathon and not a sprint. You can't just have a year or two of, of good control and the rest of the time not so good and have that kind of. This has to be as much as you can for all the years that someone has diabetes. It's such a journey that we're all on with our patients, and that we're there to support and cheer them on and help them with good medical care and good diabetes education. So our partners at the, actually at Department of Health and Human Services and the Office of the Assistant Secretary for Planning and Evaluation caught wind of this great news, and they decided to say, gee, I wonder how much money might have been saved by that wonderful decrease. So they actually took it on themselves to do some estimations on that. And then just in May, they released an issue brief called the Special Diabetes Program for Indians, Estimates of Medicare Savings. And through some modeling they did, which was a pretty interesting way they did that, they estimated that that wonderful decrease in diabetic-related kidney failure reduced, probably averted somewhere up to 2,600 cases, new cases of kidney failure. And that because of that, probably saved Medicare up to as much as $520 million over a 10-year period. Some portion of which could be attributable to the efforts of the SDPI, but all of that attributable to the efforts of us and our patients to make that happen, that reduction in kidney failure. That's remarkable. And so please take a look at that report. It's just a real tribute and testament to everything you all are doing to take good care of your patients, that we're saving lives, we're saving, how much discomfort it is when you have kidney failure. It's not painful, but it makes you feel pretty bad. It really affects your quality of life, of course. All of that has been made better because of what you all are doing. And now we have some pretty high up folks saying the same thing, that, yeah, you guys are doing great work. So those are just incredible kinds of things. So with that, how many of us here in the room have been with either the Special Diabetes Program for Indians or at least worked in Indian health in some capacity? So for those of you who've been at it for more than 20 years, raise your hands. All the old people, that's it, that's right. Okay. All right, keep your hands up. How many of you guys have been at it for 15 to 19 years? More hands, all right. How many of you for 10 to 14? Keep hands up. We're gonna get you all with your hands up here. All right. How many 5 to 9? Okay. Y'all the ones with all the energy, we're looking to you. And less than 5 years. Okay, all right. So every hand one way or another should be up, right? Because somehow or other. Isn't that remarkable? What a great group we are. Some with lots of experience and others getting that experience, but still have the energy and the enthusiasm, all of us together to make this happen. We are the ones that are making those improvements happening, that are turning around diabetes in Indian country. So I really want you all to give yourselves one big hand. All right, so where do we go from here? We need to keep up all the wonderful things we're doing on talking about good advice on diet, good advice on exercise, out there with our patients, supporting them all the time. We got to keep that up. We know that that is awfully important. But it turns out that, of course, diabetes is even more complicated than we thought it was as recently as 1997. The larger context of diabetes is what we need to start thinking more about. So when we thought in 97, I know when I went to medical school, I was taught that diabetes, type 2 diabetes, was a result of genetics, not having great genes or whatever, or having genes that made it more likely, and also lifestyle choices, those diet and exercise choices we talk about all the time. And of course that's true, but we now know that that model needs to be expanded quite a bit, actually. For example, we know that while it does matter what genes we inherit, however, the genes, the proportion of risk of developing diabetes due to genes is probably no more than about maybe 5 to 10%, depending on which group of genes you may have inherited. That's not very much. That's not the hugest part of diabetes risk, and certainly not as much as we used to think it was. So genes don't explain diabetes risk, and they further, the genes that make it more likely for you to get diabetes are no more likely to be in Native people or African Americans or Hispanic Americans, people with higher diabetes rate, than they are in white Americans, meaning that genes also do not explain health disparities in diabetes. And that's a critical thing for us to think about. We used to think, well, gosh, we have diabetes in our people because we have bad genes or something wrong with being Indian or something. But that's not the case. Genes do not explain why we have more diabetes than other populations. Sure, it can make a difference for some people, and some families have inherited more of these genes than others, but as a population, it doesn't explain it. And it turns out that the other roots that we're learning about diabetes are actually very similar to a lot of the other problems that we're seeing in our communities. Heart disease and other health problems, but also depression, domestic violence, substance abuse, all kinds of other issues. Actually, seems like we're now finding out that they all have some pretty similar roots. In some ways, I could be giving this talk at a conference on any of those topics and be saying very similar things. And that's pretty remarkable, because when we think about all that's happening in our communities, we want to help them all. We want to make diabetes less of a problem, but we also want these other things that cause so much suffering to also get better. So here's a very recent study looking at how stress and diabetes risk go together. This is a study in over 18,000 adults, and what they found was a dose-response association, meaning the more of these bad things you had, both with how much of the experiences you had, but also how many of these categories, your risk for diabetes just ratcheted up with every single one of them. Now you might think I'm going to show you a list here of things like bad choices in eating and bad choices in exercise. That's not the list. Here's the list. Having less than a high school education, having financial problems, being single or separated, being on your own, lots of stress in your life, intimate partner violence, concentrated poverty in your neighborhood, depressive symptoms, and smoking. That's not the usual list of diabetes risk factors we think about, are they? These are all things that happen quite a bit in our communities, don't they? And they also affect a lot of other problems that we see, like we were just talking about. They're all related to each other. So stress absolutely is a huge cause of diabetes. So food insecurity, another big one, and it's not, so when we think of food insecurity, it's not having consistent access to sufficient food for yourself and your family. But it's not just quantity, it's also quality, because you may not go to bed hungry at night, but what were you able to fill your tummy with? Was it good nourishing food, or was it just some inexpensive high-fat, high-carb food that you could get at the local store that maybe doesn't have much nutrition but lots of calories in it? Food insecurity is huge in our communities. One study across the country found that almost half of households below the poverty level are food insecure, including 1 in 5 households with children. One of the authors of that study, Dr. Schillinger, will be here tomorrow. I'm glad to have him here to be able to talk about these social determinants. Prevalence of food insecurity in our households, no surprise, is very high. One study found it was 61% in families with young children. 61%, almost 2/3 of our families with young children are food insecure, at least in this study. That's big, that's bad, that's something we can work on. Food insecurity isn't just something that's kind of a bummer, it's a big deal. It feels bad. Kids who are food insecure have behavior problems and depressive symptoms. They act out in school. They can't concentrate. We know that food insecurity increases insulin resistance and inflammation, both because of the foods that people have to eat when they're food insecure, but also just the stress of it increases these things. And so therefore, no surprise, food insecurity more than doubles the risk of developing diabetes. It's a huge diabetes risk factor. If you have diabetes, it significantly increases your risk of having poor blood sugar control and erratic blood sugar control. One study found that hospitalizations for diabetes out of control go up at the end of the month, because that's when the food stamps run out. And it's not just, again, the quantity of food, it's also the quality. If you take two people who are both eating 2,000 calories a day, but one of them is getting that from very nutritious foods, lots of nice fresh fruits and vegetables, whole grains, and other sources of great nutrition, and the other one is getting it from white bread and snacks and other things that are cheap and good tasting maybe at the time, but actually just don't have much nutrition. The person, even though the same calories, the person who's getting it from not very good nutritious sources is much more likely to gain weight than the other one. Food quality matters. It affects insulin levels, and insulin levels affect weight. So food insecurity is huge and something we can work on. And that's true at any age, but what we're finding even more so is that what happens early in life is especially potent for what happens later in life with our health, our mental health, our ability to get through school, to get a job, to hold a job, to do well in relationships, all of these big life things. What happens early matters because it gets programmed in when the brain and body are developing. So as the American Academy of Pediatrics said just a couple of years ago, many adult diseases, including diabetes and heart disease, should be viewed as developmental disorders that begin early in life. And further, that persistent health disparities associated with poverty, discrimination, or maltreatment could be reduced by the alleviation of toxic stress in childhood. There's a lot of powerful things in those statements. Again, turning on the head the things that a lot of us learned in our training in terms of that chronic diseases are just about choices that adults make later in life. It has a lot to do with what gets programmed into us from the earliest days. And what is this toxic stress stuff? We've heard about this, and what is that? So those of us who came last night to the trauma-informed care workshop, we talked a little bit about this. So trauma is anything that overwhelms our ability to respond. So stress is something we have to respond to, and it can get on us and drag us down over time. But something that traumatizes has totally overwhelmed our ability to respond. It can be because we're very young. It can be because at any age, something big like an earthquake or some natural disaster has happened, a hurricane or something. But whatever it has overwhelmed our ability to respond, especially if what that thing that we feel is threatened is our life or our well-being or something that supports us emotionally. So it can be, again, because something's happened directly to us, or because we're seeing maybe our mother being beaten or something, and someone who supports us, and we're only 5 years old, because that's our whole world right there. So whatever overwhelms us, that's where trauma starts coming in. And it can cause lasting changes in the brain and the body, especially when it happens when children are developing. And any later experiences which remind the brain of that previous one, maybe not our conscious brain, but part of the brain that's trying to help and protect us, called the amygdala, is paying attention to all the things that are happening around us to see if anything looks like what happened to us before, so we can maybe get protected just a little sooner if we can. And a lot of times that can be things that are in our everyday lives that are benign, not a problem, but remind the brain of that. So if you've had a lot of trauma, all kinds of things are triggering this old trauma response. So all those emotions are coming up, the fear, the anger, the sense of isolation, whatever it is, can be coming up all the time. And all those stress hormones that are associated with it are coming up too. Not only making us feel bad, but actually raising our blood pressure and our heart rate and our blood sugars and all kinds of things that over time can contribute to chronic disease. So when it happens during the development of brain and body, it can have lifelong impact. And this is a definition of toxic stress from the Harvard Center on Developing Child. The toxic stress is when a child experiences strong, frequent, or prolonged adversity. And the critical thing here is that it is also without sufficient adult help. That's when it's just really, really bad. So if you have hard situations, but you have at least one caring person who's there to say, you matter, I care about you, you don't deserve this, life will get better, that makes a huge difference. Whereas if you're going through that without that kind of caring adult support, those things are even more toxic to your brain and body development. And then, of course, adverse childhood experiences we've all heard about, and that's a particular form of this idea of trauma. So ACEs include abuse, neglect, and household dysfunction experienced before age 18. At least that's how it was defined in the original ACE study. The original study, as you all know, was done back in the 1990s, and over 17,000 people participated. It was a huge study, and 2/3 of the people in that study said yes to at least one category of adverse childhood experience. This is huge, this is common, and it's everywhere. And ACEs increase risk for all kinds of things at all levels, not just if you have lots and lots of them, but it's that same idea, dose-response relationship. The more you have, the more intense, the worse, but even having less still is an increased risk. And I think most people are familiar with the list: physical, emotional, or sexual abuse, growing up with a substance abusing, incarcerated, or mentally ill family member, parental separation or divorce, ever seeing your mother beaten, physical neglect, and emotional neglect. And your ACE score, so to speak, is the number of categories experienced, not the number of times something bad happened to you, but how many of those categories happened to you before the age of 18. So ACEs have been found both in the original ACE study and in an amazing number of studies since then. Studies that the ACE study was retrospective, looking at asking adults about their childhoods, but we've had prospective studies and other kinds of study designs that have shown remarkably similar outcomes in terms of what ACEs do. And ACEs have that stair-step kind of thing, this dose-response relationship, whatever term you like. The more of it you have, the worse, but even having less of it is still a problem. And ACEs affect, as in this slide, all kinds of things related to health, obesity, and diabetes, things that are right up our alley, right? As well as depression and suicide, heart disease, cancer, all of the, again, we're seeing again, roots of these kinds of problems in our communities have common roots, and ACEs are definitely one of those common roots. It affects our health behaviors, including whether we smoke, abuse alcohol or drugs, and our life potential, whether, again, we can get a job and hold a job, after we got through our education. Could we sit still in class when we were in kindergarten? Could we finish the 12th grade? Could we go to college? These are all things that, if things aren't going well in early life, can significantly affect our development of our brain and bodies and have lifetime consequences. So ACEs and diabetes and heart disease, some recent studies, again, just to kind of underscore the point here a little bit, I guess. The Whitehall study in Great Britain, which has been following, it's a prospective study following people for many years, found that for every additional adverse childhood experience someone had, it ratcheted up their risk for having diabetes by 11%. Every time you add on another 11% risk. And looking internationally again, across 10 countries, adults who had experienced at least 3 childhood adversities, the hazard ratio for developing diabetes, it was more than half, almost 2/3, again, the risk of having diabetes compared to those who hadn't had those experiences, and more than doubled the risk for heart disease. So if you want to get a sense for what that looks like, that means that the risk for adverse childhood experiences and heart disease is similar to the association between cholesterol and heart disease. We're all about putting our patients on statins and trying to reduce their cholesterol, right, through diet and other kinds of ways. Our adverse childhood experiences are every bit as potent a risk factor as that cholesterol. Another study, the Behavioral Risk Factor Surveillance Survey, is a national study, as many of you know, BRFIS as we sometimes call it, looked at adverse childhood experiences during several of their survey years, and in more than 45,000 people, so again, very large numbers. The ACE prevalence in that group, so this is a nationally representative sample, was very high. More than half said yes to at least one, with about a quarter of them saying yes to at least 2. Again, very high prevalence. These are not uncommon things, they are common. And again, found this dose-response relationship. The more adverse childhood experiences, the higher the risk for diabetes, for hypertension, and for dyslipidemia, for cholesterol problems. So directly looking at the kinds of diseases that we think about in our work, ACEs, again, clearly over and over again have been shown to be one of the major roots. And you might say, well, people who have had ACEs, well, it's because they have bad diet and exercise because of those ACEs, and that's why they have more diabetes. Well, that's part of it, but actually ACEs have been shown, as this study, to independently predict it. Even if you control for diet and exercise, ACEs still increase the risk significantly for diabetes and hypertension because ACEs are stressful and they create stress hormone problems. It's over and over again. It's both behaviors as well as the physiology that are altered when we've had these experiences and the resultant changes in how our brains and bodies work. So ACEs in children. So it's hard to get data on our folks very often because we are often not well represented in national surveys. However, in the National Survey of Children's Health, they had enough Native kids in there to be able to take a look at this. So over 1,400 Native kids compared with a much larger population. Of course, that same survey, over 61,000 white kids were compared. And of course, our kids, unfortunately, were more likely to have experienced more ACEs. Why do I say of course? Well, it's because ACEs are the, intergenerational. They're the gift that keeps on giving. When you've had traumatized communities, trauma is passed on inadvertently through traumatized parenting. And we've had more than our share of trauma. So it is not surprising. It is actually just the way our brains and bodies work, that when we've had a lot of trauma, we inadvertently pass it on. And so our rates are higher because we've had so much trauma. So our kids were more likely compared to the white kids to have had at least 2 ACEs, almost double the risk there, 3 ACEs, 4, and 5. All the way along, you can see our kids have a lot more trauma. And sometimes these kind of numbers contribute to us thinking, well, gosh, there's something wrong with us, right? It's really something wrong with being, Native. Maybe they're right or something. There's something wrong with us. It is not about that. It's about the trauma. Because here's an interesting thing. Within the same study, they then compared our kids alone, those of us, our kids who had had at least 3 ACEs, compared with those who had 0 or 1. Okay, so higher trauma and lower trauma of our kids, comparing them to each other. And what they found was that the prevalence of depression, anxiety, and attention deficit problems in children, behavior problems, were significantly higher in the kids who'd had the trauma, hugely different than in those who had not. It's not being Native, it's the trauma. And we sometimes forget that a lot of our kids are not growing up in those conditions. We also tend to paint everything with one brush. There are many of our kids who are blessed to be able to not be living in that situation. And one of our speakers later this morning, Valerie Davidson, is going to talk about that very issue of how do we make that happen? How do we reduce the trauma load? The traumas come to our communities from all the things, from the historical trauma, but how do we make sure that we can reduce that for the generations going forward? And so again, the kids with lots of trauma had lots of school problems and grade failures and need for meds for their attention deficit disorders, very low in the kids who had not had trauma. It's about the trauma. But we have to go back even earlier than adverse childhood experiences. You might think, well, how can we go back even earlier? Well, this stuff actually starts in the womb. Amazing that adversity can impact our health over a lifespan before we're even born. So a couple of studies here, high levels of racial and socioeconomic inequality significantly increase the risk of SGA, or being born small for gestational age, being born small, particularly when people had experienced both racial discrimination and poverty. And maternal stressful life events during the first trimester in this study, so in the first 12 weeks of pregnancy, increased the risk of being born early by almost 2.5 times. Well, why am I bringing up being born small or being born early, right? Don't we, those kids go to the neonatal intensive care unit and everything is fine after that, right? Well, we hope they do go home really well and doing great. But the problem is that some stuff has already been programmed in, and that because being born early and or small are both strongly associated with later risk for developing heart disease and diabetes. So discrimination and poverty and stressful life events in pregnancy significantly increase the risk for heart disease and diabetes later in life. So even in the earliest days of our life, before we're even born, these things can affect us, and they do affect us. The National Academy of Sciences just last week, put out a brand new report called Vibrant and Healthy Kids. It's a bit of a long sentence, but it really summarizes a lot of this well, taken from the report. Early experiences and life circumstances shape prenatal and early childhood development with powerful impacts on the developing brain and body that shape health outcomes across the life course and can span generations. This intergenerational transmission of either risk or health based on what happens to us throughout the lifespan. I really strongly recommend this report for any of you who are interested in this topic because they summarize the very most current science very well. And in fact, our next speaker, Dr. Helfand, was an advisor to this committee that came up with this, and they used his life course model as part of it. They came up with a nice little short video that I thought I would just play for you that kind of summarizes some of these things. So just really quick, to have somebody besides me saying the same things. What happens early matters. It matters across a lifespan, and there are things we can do about it because these environments in which our young families, our children grow up have huge impacts, not just on them currently, but across their entire lifespan. And for us to continue to make difference in population health, we have to address these things. So what are the kinds of things we can do then? Well, you're going to hear about this over the next few days here in the plenary sessions of the conference. There are many things that can be done that have evidence behind them. But if pregnancy and early life stress, trauma, and inadequate nutrition like food insecurity increase the risk for obesity and diabetes and all these other problems, then what can we do? We can do things like early life home visiting, things like the Family Spirit or Nurse-Family Partnership or other evidence-based home visiting programs have been shown to reduce risk both in the moms and in the children for lots of later problems, including the children are less likely to have behavior problems in school. They're less likely to have obesity-associated risk factors, substance abuse-related risk factors, all kinds of things that really matter. Early life home visiting is a wonderful intervention. Many tribes are implementing it and certainly encourage all tribes to consider doing so. I will mention Family Spirit was specifically developed in our communities by and for Native people. We can screen for ACEs or at least screen for the problems in childhood, whether we call them ACEs or not. Some tribes have decided to screen in ways that are not directly ACE screening, but something similar in order to find things that are happening right now. So if we want to prevent ACEs, but if we can't prevent them, we want to find them while they're happening as early as possible, as early in the life of the child before the impacts are less reversible. So finding them, intervening meaningfully in them is critical from the earliest point in our well child clinics, screening for depression in our young moms and our young dads, whatever it takes to improve the environment that our kids are growing up in. Something I'm just sort of calling enhanced case management or care management at all ages, but particularly, again, for young families, food insecurity, screen for it, refer to resources. We have a two-page tool on our website at ihs.gov/diabetes through our online catalog that you can download and print on food insecurity, and includes a page where you can fill in the food resources in your communities, whether it's your WIC or your SNAP or your local food pantry or church-based food bank. It doesn't matter, whatever you've got, and then put in contact information for that so you can hand that sheet to people who are dealing with food insecurity to help connect them to food resources. We even have some of our clinics now starting to provide food directly in their clinics as part of their care. What an idea that we would actually, provide food. We say food is medicine, but it's one of the one medicine we don't provide usually in healthcare, but it's the most important one. And also looking to check out whether people have good housing. A number of studies have come out recently talking about that the quality of housing affects health, both now and for the long term. So looking at housing, transportation, childcare, elder care, whether we can help them with vocational training, and of course mental health and substance abuse, the much larger picture of the environment that our patients are in. So a much bigger kind of look at our patients and partnering with them on their life's journey. And of course, there's so many things we can do to intervene, and we will hear tomorrow about traditional foods, and on Thursday and Friday, about culture as a protective factor for all of the things we've been talking about. So as I just said, over the next 3 days, we'll talk about that. So this morning, our next speaker is Dr. Helfand, and he will be talking about the life course. Then Valerie Davison will talk about adverse childhood experiences and some personal reflections on that as well as her professional ones. Early life interventions that are happening, focusing on what Alaska is doing from Dr. Matt Hirschfeld. Then tomorrow, we'll be hearing about traditional foods and food systems from Winona LeDuc. And then on food sovereignty and food insecurity in our communities from Dr. Valerie Bluebird-Jernigan from the University of Oklahoma. We'll be hearing from Dr. Jeffrey Prue from the University of Oregon, Oregon University Health Sciences. He studies stress. He's a native researcher who studies stress in people with diabetes in our population and interventions that can help reduce stress in our population. And then I mentioned Dr. Dean Schillinger from the University of California, San Francisco, who will talk about social determinants of health and how that relates to diabetes, looking at diabetes as a social disease in that sense. And then, as I mentioned on Friday, Dr. Walls and then Mr. Collins and Ms. Lugar will talk about culture as a protective factor and how knowing who we are and being centered in our cultures and who we are as Native people is a powerful and protective factor. So I mentioned this as I'm sort of winding down with my remarks here. Study, I did mention this at the last conference 2 years ago, but I can't resist doing it again because it just fits so perfectly. And it also just helps show how what we're learning has really got to be turned 180 on how we've looked at things in the past. So, and this is an old study. It's more than 20 years old now, and it relates it was a pilot study for the diabetes prevention program, the big DPP, that did eventually show that it could reduce, the lifestyle intervention could reduce the relative risk of diabetes by up to 58%. Well, before they did the big DPP, they had to test the intervention. They had to make sure it all worked and would go all right. So they partnered with people from the PIMA community to test that intervention that we now know later went on to be quite successful. So they didn't take PIMA folks with diabetes. These folks neither had diabetes nor prediabetes, but they did have obesity. And they were randomized to the PIMA Action Group, and the PIMA Action Group got that lifestyle intervention, got that intervention we now know went on to be, very helpful. And they got those 16-week structured diet and activity, exercise meetings, just like happened in the DPP study and is now going on. But they had to have a control group, and they had to get them together to do something, but they couldn't talk about diet and exercise or they wouldn't have been a control group. So they were having to figure out, what do we get these guys together to talk about for 16 weeks? So you can talk to the principal investigators. This is really what they did. They sort of said, I don't know, what do you think? Well, how about PIMA history and culture? That's not anything like diet and exercise, so let's have them talk about PIMA history and culture. So they got together for 16 weeks, and they talked about that. Well, at the end of the study, they like to measure all kinds of things. They measure weight, they measure glucoses, and they measure hypertension, blood pressure levels, anything you can think of. The PIMA Pride group did better on every single biological measure, bar none. Bar none, every single one. And they didn't get lectured on diet and exercise, but they talked about who they were and where they came from. That's a very powerful thing, isn't it? It's a very powerful thing. that's something we can learn from. And it's interesting because some of the investigators on that study, of course, it didn't end up being part of the DPP going forward because I didn't know what to do with it. What do you do with that? But it's something we know what to do with, don't we? This is important. And all of our language revitalization and cultural programs and all the rest of the things that we're doing, they matter both to preserve our culture and heritage, but also preserving our health. Isn't that an amazing thing? When things are good, they are good in so many ways. So key points I would like you to hear here, and I'm very uniquely for me, we'll be ending a couple of minutes early. We're making remarkable progress to turn diabetes around. Let's keep it up. Let's keep going. All of us who've been at this a lot of years, we've figured out some things to do, and those of you who are newer to it, as we saw when we all raised our hands, you guys are here to pick up the baton and run with it. Let's keep up the excellent medical care that it takes to prevent complications. Let's make sure we're getting those ACE inhibitors and those statins and and glucose control and all those things that we need to do in order to help prevent complications in our people with diabetes. And let's keep up, telling our patients about encouraging them and being active, because being active feels good as well as, helps, reduce risk for disease. And these are all good things. Let's keep at it. But many of the roots of diabetes, as we've been talking about, are similar to the roots for some of the other problems that are breaking our hearts and our communities. And this new paradigm, this new understanding, this demands some new approaches, as you've been seeing and we've been talking about. And many of you are already doing. Many of you already are doing things like stress reduction that Dr. Prue will talk about. You're incorporating meditation or Tai Chi or yoga. You are screening for food insecurity. You are doing these other things. Understanding the real roots of diabetes, these bigger, broader roots, demands that we do bigger and broader things. But the payoff is that we're going to help prevent many things. So what would we do if we really get it? If we really understand that trauma and poverty are the roots of so many of the problems in our communities, including diabetes and obesity and heart disease? What would we do? What will we do when we go home? How can we be the one? It can be something as small as when our colleagues are saying, well, if, Mr. So-and-so would only do what I tell them about, his sugars would be better and he wouldn't get bad problems. That's not a good perspective. What's going on for that patient is much bigger. And diabetes just didn't make it to his top 3 that day or that week or that month of things he had to deal with. And if we understand the stresses and the traumas that our community members are going through, we won't speak disparagingly about that. We'll try and help his blood sugars come down. We'll do what it takes. Maybe it's because he is food insecure. Maybe it's because he only has access to things that are not healthy for him. Or maybe he has, a loved one who is dying, or who knows what it is. There's something else going on. As we've talked about, A1C can be a better measure of how in or out of control your life is, as much as how in or out of control your diabetes is. So having that compassion just to treat our patients differently, that alone is world-changing, let alone being able to implement some of these bigger, broader things and programs that we'd all like to do in order to be good teammates with our patients on their life journeys with diabetes. Being the one, being there for that one kid who doesn't have it so easy at home, but you can be that one person who gives them a hug and lets them know that they're okay, that they're loved, that you're there for them. These things matter. Sometimes it's the small things. It's about kindness. It's about compassion, and seeing that through the lens that instead of blame, which is what we do too often in medicine, and we blame people for their diseases and their problems, let's shift that and see them through the lens of the eyes of compassion, and that we're all just doing the best we can with what we were given. But because we are Native people with all of the tools at our disposal, our proud heritage, all of the strengths of our cultures and our communities, we can do better. And we can pick up everyone, not leave anyone behind, move forward in this great journey that is turning around what has happened in our communities, from pain to joy. We have much to celebrate as well as much work to do. And with that, let's take about a 5-minute stretch break while we get geared up for our next session. Thank you very much.